Vaughan-Lane with us today. We'll be recording the talk. I hope that's okay for everyone. Yeah, we're going to be talking about some MSK related content, and we'll be going by joint. And at the end of kind of each section, each joint, there'll be an opportunity to ask questions. And yeah, it will take roughly 1 hour. And Tim has kindly agreed to send us the PDF of all the slides afterwards later this week. So I can distribute that to anybody who's at the talk today. So even if we don't finish everything, don't worry, it will all be in a PDF. Over to you, Tim.
Okay, right. Well, as you may know, I'm an orthopedic surgeon, trained at Birmingham University in 71, qualifying in 71, a long time ago. I sold my soul to the Royal Air Force for the princely sum of £1,000 a year. So I then stayed in the Air Force for a few years. I then went to Hinchingbrooke Hospital in Huntingdon, where I stayed for nearly 30 years, then became a senior anatomy demonstrator and a Murray Edwards By Fellow. I thought you might like a shot of me on the year before I became a consultant. Time flies. So there are 4 parameters before you do anything else. Listen and ask, look, feel, and move. So if you remember all of these things in your consultation, you won't go wrong. And don't forget, with regards to movement, it can be active or passive. There. Right. The other thing, never forget, always remember referred pain. As you know, pain in the shoulder may come from irritation of the diaphragm, and pain in the knee may be referred from the hip, which we will talk about later. So on to the shoulder. First thing to look at is the acromioclavicular joint. And the acromioclavicular joint is a frequent injury in rugby. And it may be dislocated, as it is here, or it can be subluxed. And a subluxation is where there's still partial actual connection between the joint surfaces. If it's markedly dislocated, then you can put in a tape which goes from the coracoid to the clavicle, replacing the conoid and trapezoid ligaments. A little bit about osteoarthritis. It does occur in the actual acromioclavicular joint, and you can see some of the classical actual appearances of an osteoarthritic joint. As you all know, sclerosis, loss of joint space, and peri-articular actual cysts. So what about the glenohumeral joint? As you can see here, this shoulder looks vastly distant to that shoulder. I think this gentleman was extremely stoical in allowing himself to be photographed with clearly an anterior dislocation of the shoulder. You can see that flattening there, so the humeral head is no longer present. Things to consider include a deltoid palsy, which is manifested by, you remember the regimental badge around here. It would be rather churlish to ask this chap to abduct his shoulder at this sort of stage, but after the actual shoulder is reduced, then you may well want to actually test his deltoid function. Complications, apart from a deltoid palsy of an anterior dislocation, are recurrent dislocation, and that may require surgical stabilization. So here we have a normal, I'll just see if I can get rid of the thumbnails. There we are. So that, by the way, I'm not Dorothy, I'm using my wife's computer, by the way. So normal appearance of the humeral head beneath the acromioclavicular joint, and here's a classical anterior dislocation. Probably 80 to 90% of shoulder dislocations are anterior. This is the more unusual actual posterior dislocation, which can occur in patients who've had an epileptic fit. In the bad old days, ECT was administered to patients who'd have an anesthetic but no muscle relaxant. Amongst the injuries they could sustain were posterior dislocations of the shoulder, as well as vertebral body actual fractures. This is the much more uncommon inferior dislocation of the shoulder, where the patient comes in with their arm fully abducted. It generally occurs in falls, but it can also occur in the condition of habitual subluxation, where a patient is able to dislocate their shoulder at will. And I've seen a patient who managed to actually demonstrate anterior, posterior, and inferior subluxation at a clinical meeting. So, other bits around the shoulder, soft tissue lesions, a subacromial impingement. And here is demonstrating one of the causes of subacromial impingement, and that is an osteophyte on the acromioclavicular joint. You can also get congenital abnormalities of the acromion and so-called actual unfavorable actual acromion, where the acromion, instead of being like this, hooks down and causes inflammation above the supraspinatus tendon. A subacromial impingement classically involves a actual rotator cuff arc. So this arc of movement is actually painful from 60 to 120 degrees, but there's no pain on either end of the actual painful arc. A acromioclavicular joint osteoarthritis will tend to produce a high painful arc from 120 to 180 degrees. So what about a tear? If this progresses, then you can get a tear of the rotator cuff, which the patient will present with increasing pain and loss of mobility, and an inability to abduct the arm beyond about 60 degrees. That's an active movement, but passively, the patient, you may be able to raise the actual shoulder completely. And this will require a rotator cuff repair. So what about humeral fractures? First one I'd like to talk about is the fractured neck of humerus across here. And this is defined because it occurs in the elderly as a fragility fracture. A fragility fracture is one which occurs more easily because of osteoporosis. I would emphasize with the humeral fractures, you need to be on the lookout for various nerve palsies. With the fracture here, then you're going to be looking at an axillary nerve lesion. If you have a mid-shaft, particularly an oblique fracture of the humeral shaft, then you have to think about the radial nerve. And this is essentially a kiddies fracture, in which both the median nerve and the brachial artery are actually at risk due to the marked displacement of the actual fracture fragment. And you can see the classical appearance of swelling and bruising, and also skin tethering, that this is very common to see in displaced actual fractures around the distal humerus. And this is the classical deformity that you will see in a child. This requires urgent reduction, and this can be achieved generally by actually just a manipulation under an anesthetic, but you may need to hold it in position with some crossed wires here. One of the problems of this, apart from the acute injuries to brachial artery and median nerve, is that you can get a deformity of the actual elbow and joint distal to the fracture because of the malunion, and then you get altered actual epiphyseal growth. And this is a fracture deformity, but you can have a deformity similar to this, where you get a valgus deformity with the arm abducted away from the midline. But if you get a varus deformity of an elbow, you have a so-called gun stock deformity, like the stock of a gun, and this requires surgical treatment to correct it. So malunion and altered epiphyseal growth are a complication. So that was a very quick run through of the shoulder. I don't know if there are any questions. If not, we will move on to the elbow. We've already seen the supracondylar fracture, but this is a fracture of the radial head caused by a fall onto the outstretched hand. Another one of those FOSHs. I hate acronyms, but FOSH will often appear in notes, fall onto outstretched hand. In cases sometimes where you can't see a fracture of the radial head, you may have to look out for what's called a fat pad sign. That appears on X-ray as a sort of translucency, and you can just about see that here. And that indicates that there's a hemarthrosis in the joint, which has lifted up this fat pad. A fall onto the outstretched arm will classically cause a fall directly onto the elbow will cause a fracture of the olecranon, and this is fairly easily stabilized with wires and a figure of 8 loop, which compresses the fracture. You all know about golfers and tennis elbow, and you did a work on this in your anatomy. Right, so now talk about bursae and bursitis. The bursa, Italian for a purse, a borsa, is a synovial structure, so it can swell. And this is classically called the student's elbow, from all those hours spent in the library in despair with your elbows on the desk. So it also occurs in lorry drivers who actually sit with their arms resting on the actual window. Treatment can be by way of local steroid injection and sometimes even by surgical excision. A quick trip to the knee, there are 2 bursae around the knee, prepatella and infrapatella. So-called housemaid's knee, where as they scrubbed the floor and bent forwards and backwards, so the prepatellar bursa got quite irritated and swollen, whereas clergymen are thought to pray in an upright position and therefore get an infrapatellar bursitis. Non-steroidal anti-inflammatory drugs or steroid injections are often helpful for this. And this is not to forget that because this is a synovial structure, inflammatory conditions such as gout can actually affect these bursae. Now into the forearm. Forearm fractures, one has to be very aware of with regards to their complications. And forearm compartment syndrome is really, or can be, a life-altering condition. As you know, you get all the P's. You get pain, followed by paresthesia, followed by pallor, and followed by paralysis. And by paralysis, one means that the fingers are tending to flex down, and any attempt to extend the fingers causes very acute pain in the arm. And what is required is an ample fasciotomy. In this particular case, you can see the patient's already had a carpal tunnel decompression to relieve pressure in the hand. But this is the extent of the actual decompression. And then you don't close the wound primarily, but you'll close it again 4 or 5 days later. But the swelling may be such that you need to skin graft. The unfortunate consequence of an actual compartment syndrome is the classic Volkmann's ischemic contraction. The wrist is pulled down due to the fibrosis in the flexor compartment, and the actual fingers are in this classic position with MP joint extension and IP joint flexion, and the elbow is flexed. The only treatment for this is to actually remove all of the scarred tissue, but this will often leave with quite a actual deficit, such that further treatment may be required, such as wrist fusion, to try and improve the arm function. Now, wrist injuries, we'll start with the classic Colles type fracture, where there is dorsiflexion of the distal fragment with ulnar deviation and abduction. This again is a fragility fracture, and it is vital with fragility fractures that you initiate a actual bone density scan, as patients should actually receive appropriate treatment for osteoporosis if that is demonstrated on a bone density. Complications of a Colles fracture, apart from malunion, is carpal tunnel syndrome, and we'll go on to that in a little bit. But here you can see a classical Colles fracture. Now, I took some of these pictures off the net, and this particular one is something that you should never see in a presentation, which is the full name and age of the patient, unless you have specific permission. Occurring in younger patients is the scaphoid fracture. Again, it's a fosh, but it tends to be onto a more abducted wrist. If patients present following a fall with tenderness in the anatomical snuff box, they should obviously have an X-ray of the actual affected wrist. And here you can just about see a scaphoid fracture. But sometimes you may not see any evidence of a fracture. But if there is anatomical snuff box tenderness, patients should be treated in a splint or a cast for 10 days and then re-X-ray, by which stage the actual fracture should be more apparent. The importance of treating a scaphoid injury is that if the scaphoid is malunited, then it leads to wrist instability, and patients have a painful wrist, which really makes the hand not such a good tool. And this can be treated and stabilized by a screw across the fracture. One of the complications of a scaphoid fracture is avascular necrosis of the proximal segment. As you will remember from your anatomy, the blood supply is from distal to proximal. And if that is severe, then the patient may need a wrist replacement or a wrist fusion. So I mentioned carpal tunnel syndrome just now, the condition par excellence, which examiners love to talk about. So carpal tunnel syndrome is more common in patients who have got repetitive work in the hand. Pregnancy is also something that a carpal tunnel syndrome is more common in. And this may be due to fluid retention. The paresthesia may often be worse at night, and people describe having to shake their hand. Now, this may be due to a couple of things. A, we retain fluid at night, and B, people often tend to sleep with their hands flexed. And so therefore that will reduce the actual volume of the carpal tunnel, and therefore the median nerve is compressed. Although this is the classic distribution of the median nerve, it can sometimes be different there. Testing for carpal tunnel, you all know the Tinel's test, where you tap on this area, but also there is Phelan's test, where the hands are palmar-flexed for a minute, and if they describe paresthesia, that's positive for a carpal tunnel. This is one of the ways we treat it, and that's with a cock-up splint. So that stops the patient getting symptoms at night. Local steroid injection can also be helpful to relieve the pressure within the tunnel. In older patients, you can often see quite marked wasting of the thenar eminence. Unfortunately, surgery does not lead to recovery of motor function here. And this is the example of the carpal tunnel decompression, where you can see this is the edge of the flexor retinaculum, and here is the median nerve, which is relatively pink. And often when you're operating, when you initially open the retinaculum, the nerve is quite flattened and white, but then it will rapidly pink up, which is why I always prefer to do the operation without a tourniquet. Other inflammatory conditions around the wrist includes de Quervain's tenosynovitis. My granddaughter is just finishing her 4-year actual modern language course, which included Spanish. And this involves pain on use of the thumb. Again, local steroid injection can be helpful, or you do a surgical release. Trigger finger is something that occurs particularly in diabetics, and it causes the finger to be flexed down into the palm. You can often find a little nodule which you can palpate within the palm there. And patients describe going to bed with a normal hand, and they wake up in the morning with the finger flexed down, and then they have to straighten the finger with a painful click over there. This appearance may be due to, it's not, but may be due to a Dupuytren's contracture, but it would then be permanently flexed down and wouldn't actually straighten. If you want to see a good example of Dupuytren's contracture, look at Bill Nighy, the film actor, and you'll see, particularly when he's holding a door, as he puts his hand round, the fingers are flexed down. I don't know if anybody has got anything they wanted to ask about what we've done so far. No? Well, I'll move on then.
Oh, sorry. I just have a quick question.
Yes.
So with the trigger finger there, did I miss, did you say anything about the treatment of it?
Oh, no, I should have said, again, it is injection and then possibly surgery.
Okay.
And you just flex the you just divide the flexor sheath.
And is that, how effective is that surgery in preventing it coming back again, or does it tend to recur?
I did quite a lot during my career, and there was only one chap who had fairly severe diabetes, who was, you know, insulin dependent, in which it came back. Generally, it's pretty successful.
Thank you.
Okay.
Sorry, could I ask a quick question as well?
You don't have to apologize if you want to ask a question. It's fine.
With this same condition, what sort of population does it tend to affect? Is there a particular occupation or?
With the diabetics, it's often sort of younger adults in their 20s or 30s, but it can occur in older folks who don't have actual diabetes. So it's more young adult with diabetes or an older patient without.
Thank you.
Okay. Right. I was just going to then say about the lower limb, with conditions from developmental dysplasia of the hip through to Perthes and slipped epiphysis, then to the athlete with his meniscal and cruciate injuries, and then developing osteoarthritis. So some of the slightly different conditions around the hip include a bursitis. This is a trochanteric bursitis, and this sort of tends to affect people who are doing repetitive activities such as running, whereby it rubs underneath the tight iliotibial tract just here. And so physiotherapy is often the treatment for that. There is one other condition which affects the hip with regards to the iliotibial tract and TFL, and that is you can get something called a snapping hip, where the hip on flexion extension snaps backwards and forwards. And people may present in clinic to you saying that their hip keeps dislocating, but that's unlikely, because they wouldn't be able to walk afterwards if their hip was dislocating. So if you flex the knee with a patient on the couch and bring the actual leg up towards the abdomen, then you will often be able to palpate this actual snapping of the hip. And sometimes it's so loud that it makes people jump. So snapping hip, again, physiotherapy is the treatment for that. We've also now come to recognize that sometimes there is an abnormality between the neck and head, which causes a sort of bulging of the neck, which then catches on the acetabulum, a so-called impingement lesion. This may be secondary to some adolescent hip conditions, but we also see it in patients with no history of that. And so whether they're just born with a slightly abnormal hip, but that will require very often arthroscopic surgery there. One little thing that I would mention, I have only ever seen one case of this, and that was in fact when I was serving with the Royal Air Force in the Persian Gulf. And this is a psoas abscess, which tracks down and presents in the femoral triangle. So swelling around the hip, just be aware of that. It can occur as well with non-tuberculous infection. The actual fluid which is produced from joints in TB is not the sort of pale yellow of a synovial effusion, but is often milky in consistency. I have to say, I worked at Luton and arthroscoped a patient with a swollen knee, which nobody could find a cause for. And out came this milky fluid, which at the time I had no idea what it was. But fortunately, the anaesthetist at the head of the table said, "Oh, he's got TB." Thank heavens for senior colleagues with experience. So, severe trauma around the hip and classic appearances of, for example, a posterior dislocation of the hip will often occur with motor vehicle traffic accidents in which the patient is restrained in the driver's compartment, but the dashboard is pushed in, forcing the actual hip back and out posteriorly. It often takes, as is here, a small fragment of the acetabulum with it, but it can sometimes take big triangular fragments of the acetabulum, in which case you would need to actually reduce and fix the fragment with screws. Complication of posterior dislocation is a sciatic nerve palsy. As you all know, the sciatic nerve is directly behind the hip joint. It requires reduction by actually pulling on the leg, so extending it, externally rotating it, pulling it down, and then you should be able to internally rotate, and that reduces the hip. The patients then have to be on restricted weight bearing for some while. You can sometimes get a vascular necrosis of the femoral head as a complication. This is the much less common anterior dislocation. When I was in the Gulf, this patient was driving a dumper truck with his leg sort of abducted, as people might do, putting their arm outside the window of a car. He had his actual leg outside the confines of the dumper truck. He didn't get turning the corner around the actual building correct, and he struck his abducted leg very firmly on the side of the building, causing the actual dislocation of the hip. You can see this patient has already been catheterized there. So always be aware on x-rays, if you're asked to look at one and comment on this, don't necessarily be drawn immediately to the obvious anterior dislocation. So look carefully at the outline of the pelvis and note any peculiarities there, the catheter there. The other thing to say about these dislocations, that these can be incredibly painful. This chap's dislocation was actually at the neck of the scrotum. So whenever somebody tried to move it, it produced traction on the spermatic cord, which was uncomfortable. So on to something you will all see in our patients, which is the classical osteoarthritis of the hip. I'll repeat again the signs of osteoarthritis: sclerosis, loss of joint space. Here you can see some actual cysts which occur, which I'm never quite sure of, and I don't think anybody's precisely worked out the actual pathology of, and these osteophytes there, which cause a painful restriction of movement. One of the first movements to be lost is internal rotation. So the patient has an externally rotated leg, and this often produces a lot of pain at night. So it's one of the actual things that is painful at night. Other conditions may well settle. For example, knee arthritis is not so painful in bed, merely when weight bearing, whereas hip arthritis is painful in bed. Treatment, when patients have got a lot of pain, is by way of total hip replacement. This is a total hip replacement with both the acetabulum and the femoral components having been replaced. And these can have very good long-term results. In series with expert hands, you can have 85% survival at 20-25 years. This is the more, if you like, modern resurfacing hip arthroplasty, which Andy Murray is an example of. He had a resurfacing. The advantage of this is that when this loosens, which is the long-term complication of joint replacement, you can then put in a total hip replacement, so you've gained time. Sometimes you can get a better range of movement with a resurfacing arthroplasty. Generally, the actual metal or ceramic head articulates with a high-density polythene lining. But some surgeons have used a metal-on-metal prosthesis. Unfortunately, this can, in certain patients, lead to a metal sensitivity, and you get a giant cell reaction. And so you get big cysts which form around there and premature loosening of the actual hip replacement. And this can be difficult to put a total hip replacement into if you've got dirty great holes around here. So it makes it a more complicated procedure. So fractures around the hip are classic fragility fracture, as you know, of the neck of femur, in which the leg will actually lie internally rotated and shortened. Generally occurs in the elderly after a fall. And one should just say that apart from looking at the fracture, you should determine whether the patient is what the reason is for the fall. It may be a trip over a loose carpet, but they may be on hypotensives and have had and it hasn't been monitored, and their blood pressure has been getting lower and lower, and that's one of the reasons patients might fall. So like doing bone densities, always question why the patient has fallen. Treatment, if the fracture is undisplaced, is by way of internal fixation, and you can see 3 screws have been used to do that. But if, as here, the fracture is markedly displaced, it's unlikely that this is going to heal well, and there's a risk of avascular necrosis of the femoral head. So a lot of people will now perform an actual total hip replacement as the primary treatment. Patients don't seem to get quite as good function, but nevertheless, they're up and around and walking extremely quickly afterwards, because infection is uncommon following this sort of treatment, but you also need to be aware of, so patients are always given antibiotics around the time of the operation. Other complications of joint replacement include deep vein thrombosis, so patients have surgical stockings and have things like subcuticular heparin for some while following the procedure. Some of the work which was done originally on the incidence of DVT following a fractured neck of femur was really not a strict comparison with what we do now, as they could be restrained in bed for 3 weeks or so afterwards. Right. Any questions about the hip? Okay, so on to the knee. And thinking about the knee, you need to be thinking of structures perhaps outside of the knee, the bursae, and don't forget the pesa anserinus, which comes down here, say grace before T, sartorius, bursa, gracilis, semitendinosus. So remember that order. It tends to be an overuse type of actual condition, and generally physiotherapy will settle it down, rarely a steroid injection. Other things you can palpate around the knee include the typical tibial tubercle, and this can cause pain in the adolescent, so-called Osgood-Schlatter's disease, and again is treated with physiotherapy. It doesn't need absolute rest, but young people may need to modify their activities. We've discussed the iliotibial tract up nearer the hip, but this now can cause similar pressure problems around the knee, a so-called iliotibial friction band syndrome. And this again tends to be an overuse type of injury, particularly in runners. Stretching activities or physiotherapy is often helpful. Now, you can notice in this patient that the patella is not in a good position. It is dislocated. Patella dislocation can occur traumatically, but probably more commonly, you can get actual conditions of the patella, which include pain, so a patellofemoral syndrome, but it can include a very flattened trochlea, so that the patella just skates around, and treatment by way of surgery is needed, but it doesn't always produce a normal joint again. So it's one of the problems of orthopedics. And then obviously to things inside the actual joint. You can fracture your patella by a direct blow by falling forwards onto the knee, and again, typically occurs in younger adults, but can occur in elderly patients with osteoporosis, and that's treated by fixation, very similar to the olecranon by way of wires and a figure-of-8 wire over the top. With regards to the articular cartilage, you can get loose bits, loose bodies, so-called osteochondritis dissecans, and this produces pain, swelling, and intermittent locking, that it doesn't stick absolutely, but patients describe a feeling that something's catching in the knee. They can't move their knee for a little while, and then it suddenly releases. We'll discuss ligaments, by a little bit about MCLs, but anterior and posterior cruciate and menisci. And don't forget, all synovial joints contain synovium, synovial fluid, articular cartilage, and bone. So any of these can be a problem. So talking about the menisci, this photograph of a footballer is a good example of how to tear your meniscus. His actual foot is clearly anchored by studs in the ground. And if he was to rotate medially, he'd probably get a medial tear, or laterally, a lateral meniscal tear. And this is an example of a meniscal tear. The patient will present with pain and swelling, but the swelling comes on gradually. It is a synovial effusion, and the joint isn't particularly hot. You may find as well that you can't fully straighten the knee, and this may be due to the meniscal fragment getting locked between the medial femoral and tibial condyles. The locked knee. Treatment is diagnosed these days with an MRI scan, and then arthroscopically either removing the torn fragment, or it is possible, this horizontal tear, to be stabilized with sutures. But you can only actually deal with this tear if it's in what's called the red on red zone. This patient has already had part of the meniscus removed, and this area, the 2/3 attached to the capsule, does have a limited blood supply. So it's worthwhile trying to suture this, because if you totally remove a meniscus, you're much more prone to osteoarthritis in later life. So ACL injuries involve much more force, with rotation of the femur inwards, the tibia outwards, and often an abduction injury as well. And if this force increases, then not only do you damage your medial collateral ligament, you tear your meniscus, but you also rupture your anterior cruciate ligament, the so-called unhappy triad, which was attributed to O'Donoghue. However, Vaughan-Lane's quartet involves even more injury, where the lateral femoral condyle acts like a chisel on the tibial plateau, and so you get a tibial plateau fracture. I'll talk about the anterior draw test in a minute, but you can see the classic position for somebody who's just about to tear their anterior cruciate ligament. Although very rare, and I've only seen a couple of cases, it is possible to dislocate your knee. As you can see, this is the normal appearance of the right knee, but the left knee is hyperextended by 90 degrees, such that the actual lateral femoral condyle is what is hitting the turf at this stage. These sorts of injury often involve very serious vascular and nerve damage. So knee dislocation, very rare, but when it does, it's a positive emergency. Some of the tests that you might like to do in actual orthopedic practice include the anterior drawer sign. And it is drawer, not just draw. So it's the drawer who finds that they can move the tibia forwards more than 5 millimeters, and that is a positive actual anterior draw test. The PCL is more a look sign than a move sign, in as much as here's where the tibia should be, but it sags backwards. And you correct it by pulling it forwards there. But you see the sag to start with, so you're pulling it up to the actual normal position rather than with the anterior draw, where you are pulling the tibia forwards of this line. You will see in the books about a test for an effusion is a patella tap. This involves you pushing the patella down and you get a knocking feeling as the patella hits the trochlea. However, in my opinion, if the effusion is that great, you can see it anyway. So it's a pretty useless actual test. People also describe McMurray's test for a meniscus, which describes having to fix the femur and then rotate the tibia on it. And you get a painful click if there is a posterior horn tear of the medial meniscus. But people describe using a McMurray's test to test for all different sorts of meniscal lesion, and that's not true. It's very specific. So PCL injuries. We've already discussed dashboard injuries, which may damage the, may posteriorly dislocate the hip, but it can also actually tear the PCL. Also, it can be caused by a direct blow, particularly with somebody who's running forwards or hyperextending the knee. You remember that the posterior cruciate ligament comes up from the posterior part of the tibia to move forward into the knee, and it's this attachment posteriorly on the tibia which is torn. Here is another way of doing it. This actual player, rugby player, is actually falling forwards, and he's going to hyperflex the knee with the foot in plantar flexion. So another way of tearing your PCL. PCLs tend to be not quite so incapacitating as an ACL injury. Reconstruction involves using the hamstring tendons taking them from the pes anserinus, and you get remarkably little loss of actual function from taking gracilis and semitendinosus. You fold them over into a 4-strand technique, and with the PCL, you have to make a tunnel here, you pull some threads through there, and then you pull threads through another tunnel. Tibial fractures, tibial plateau, you need to always be aware that tibial plateau fractures can involve compression of fragments. So there is part of the actual tibial plateau which has been forced down into the actual tibial shaft almost. And so this needs to be elevated if you're not to rapidly develop osteoarthritis from malunion and a incongruity of the articular surface. This occurs in a fall from a height. Compound fractures are these days often dealt with by external fixators because the high risk with a compound fracture is of infection. Internal fixation allows patients to get up early, get their ankle and knee moving so that you don't get this complication of stiffness if you treat people in a plaster for 12 weeks. Predisposing factors for OA of the knee, I will go through very quickly. Congenital, varus knee, gross obesity, and trauma. I was once patient with BMI of 54 for consideration for a joint. Mean patient's arthroplasty was likely to fail sooner rather than later. Knee replacements are very successful. You can replace. Lateral compartment OA is a more serious condition than medial compartment, in as much as if you were to take a line from the hip down, you could see with a valgus knee, you cannot, with a valgus knee, you cannot get your ankle under your hip, and therefore you have very limited opportunity to correct this conservatively, and this needs fairly quick surgical treatment. Alignment is important, that you get it, do apologize, aligned correctly. I used to use computer navigation such that you can record that the patient before surgery had a 1 degree flexion deformity, but with 15-degree varus, and afterwards this had reduced to just 2 degrees. Foot and ankle, just very quickly, ankle sprains, classical ankle sprain, swelling really around the lateral ligament with some tenderness over the subfibular area in this area, whereas with a fracture, it's more likely to be around the ankle joint as such. Most important for these to be openly reduced and internally fixed in order to prevent osteoarthritis. Although you can treat fractures in plaster if there's inadequate reduction, as you can see the talus is moving across here, then you should fix that as well. And lastly, just at the end, hallux valgus and hammer toe. As you remember, valgus is where the joint points away from the midline, and this is often caused by inadequate footwear, these stiletto heels of years gone by. And this can be actually surgically corrected. One example of this is the side view of your metatarsal head, and you can move that laterally, and that maintains the height of the metatarsal, so relatively good actual function of the foot. These hammer toe deformities you treat by what's called an excision arthroplasty. So you remove that piece, straighten it, and put a wire down it for 6 weeks, and that generally gives you a more comfortable foot. So that is a gallop through the actual muscular conditions, some of them. I'll put a few more in my PDF, but I don't know if anybody's got any questions.
I've got a question. That's right.
Yeah.
In terms of patellar tendonitis, what kind of treatments are there?
Sorry, excuse me. The treatment for a patellar tendonitis can involve physiotherapy, ultrasound. Sometimes you need to always be looking at alignment of the actual leg distal to the knee joint. Have you got an overpronated foot, or that sort of thing, which can cause it? Because there's not a synovial sheath, there's not really any place for a actual steroid injection. You may find the use of non-steroidal anti-inflammatory gel helpful, and sometimes using a little small heel raise can be effective, and just taking the pressure off the extended knee, because it's as you extend the knee, so you will often get more pain. So the treatments are limited to really conservative.
Thank you.
Okay. All right, so I'm very sorry that that was such a rapid gallop, but as I say, I'll put that all in paper form via a memory stick, but I will get that over to Isabella, and she can then distribute it as appropriate.
I've just put a link to a Google form in the chat, and if you could fill in the form to get access to the slides, that'd be great. Thank you.
Right.
Does anybody else have any more questions?
Okay. Well, thank you for your forbearance, and all the best of luck to you.
Thank you.
Cheers then.
Thank you. See ya.
Thank you.
Bye.